Hello everyone. Let's get started and try to see how we can kind of give an initial introduction, and then we have a break, and then we'll be back and start the course officially. So my name is Hamid Ektiari. I'm delighted to be here, and I have greetings from my co-chair, Professor Alex Baldacchino, who was not able to make it to Alexandria today, but I'm happy that we are here, and I'm here with a group of really kind of knowledgeable colleagues here from different institutions, and we have Dr. Rania, Dr. Rama, Dr. Yasser, Dr. Fares, and gonna be a fantastic course discussing about different things regarding addiction psychopharmacology in the context of World Psychiatry Association meetings, okay? So, my talk is gonna be mainly about neuroscience. So, the question is how neuroscience can inform medication prescription in addiction medicine, addiction psychology. So that is the introduction. And then we will have other speakers going to different substances. We will discuss about different medications, different protocols. So we will have time till 8 p.m. today to further discuss about medications, and we will discuss about different nuances of clinical practice, because we have colleagues from Qatar, from Saudi Arabia, from Lebanon, from Switzerland, from Egypt. So we can even discuss how things are a little bit different across different clinical practices around the world. You have my slides in the QR code. Do you want to try the QR code, see if the QR code is working here? So, and whoever is here in the workshop will be happy to send the slides to you as a PowerPoint, so you can just use it in any way. So you have my permission to use the slides and material in any way that you want to basically educate others in the field of addiction psychiatry, addiction medicine. So does it work? Yeah, it works. Okay, so it's a Google Doc. It works? Good. So it's a pretty heavy file, but I mean, at the end I will provide the QR code as well at the end to just make sure that we'll have the slides to be able to have access. And we are recording the workshop as well, and we put the videos together, so we'll have access to the videos as well. Okay. So I work at University of Minnesota, Department of Psychiatry, and also Center for what we call Neural Circuits in Addiction, Department of Neuroscience. So I'm being trained to be both psychiatrist and neuroscientist, and trying to develop new treatments based on the background that they have in neuroscience. My lab is mainly focused to use different technologies that we have to develop different, what we call neuromodulation technologies. And as you know, there are lots of really interesting, exciting new advances in developing different neuromodulation technologies, brain stimulation technologies, from things like TMS to different sort of vagal nerve stimulation, deep brain stimulation, different types of deep brain stimulation, responsive deep brain stimulation, and other modalities that we use for brain stimulation. So this is what my lab is mainly focused to develop new technologies for psychiatry. And we use different kind of ways of doing that. We use brain imaging and robotic arms. Right now I'm using robots to be able to target a specific neural circuits that are important for addiction and target them in an individual way to be able to use that for addiction treatment. So these are the technologies that we use. And University of Minnesota is the first center in the world that did the initial fMRI studies, functional MRI studies. So there are two largest brain imaging centers in the US. One is in Harvard, the other is University of Minnesota. So these are the two largest brain imaging centers. So we use those kind of resources to be able to tackle the issues of drug addiction. And I'm very interested to see how neuroscience could be used in clinical practice in addiction. I have a textbook, 2 volumes, 38 chapters, discussing about how neuroscience could inform addiction psychiatry, addiction medicine. This is the QR code, and I'm working on the second edition of that, but the first edition the ebook and everything is available on the QR code, so you can have access to the book. I do not have any conflict of interest. I'm not receiving any specific kind of financial reimbursement for my talk here, and I will discuss a little bit about off-label use of medications that we'll further discuss today. So I'm going to start with a case vignette today, and we are going to think a little bit about that case vignette and see how our understanding about neuroscience could help us to decide what will be the right medication for this specific case vignette. So we have Mr. Z. We are in Egypt, we can say Mr. Ziad, okay? Mr. Z, 40 years old, divorced man, businessman, who is seeking treatment for his methamphetamine use, okay? He was drinking alcohol when he was in high school, was using cocaine in parties, and he reports that he was able to have better focus and getting things done and feel normal when he was using cocaine when he was in college, okay? And then he reports that he had serious issues with cocaine use before when he was younger, but he's not using cocaine anymore. He is mainly using methamphetamine, just few times a month, not very frequently, and does not meet criteria, or at least he does not report in a level that you can put the full criteria for amphetamine use disorder for him, okay? He doesn't have any history of intravenous drug use, any opioid use, and any overdose in the past. But he's concerned about his methamphetamine use, and he wants that to be addressed, okay? Mr. Z has a 11-year-old son who is being diagnosed with ADHD, and he is already receiving Ritalin or methylphenidate for ADHD. He tried his son's medication, and he reports that when he's taking Ritalin, he functions much better. And he thinks that he might have ADHD. That's the reason that he can function better on Ritalin. He knows that it's not a good thing to just basically use the son's medication, but we appreciate that he's honest and he was sharing that with us. And now the question is how we can address that. He's currently on ACE inhibitors and diuretics for hypertension. So he has hypertension as well, okay? Past history, he was doing reasonably well in high school, not doing really well in college. And then when, the college was without structure, he was struggling. He had lots of issues with procrastination, not being able to get his schoolwork done, and he has never been assessed for ADHD. Okay, so these are the other pieces of the case vignette that you have, okay? So the question is, how do you treat ADHD for Mr. Z? Let's think that we already have here people who have neuropsychology background. We send Mr. Z to a neuropsychologist, or you do a comprehensive assessment for ADHD and say, okay, yes, he has ADHD. How do you treat ADHD for Mr. Z? That is one question. How do you address meth use in Mr. Z? What else do you want to know about Mr. Z? Let's start with this question. What are the other clinical pieces of information that you need and you are interested to know about Mr. Z? On Mr. Z, I'm happy to answer your questions. So who is interested to ask a few other questions from Mr. Z?
First, I want to assess his history. His hearing of ADHD, and I want to make a scale to have objective measure, not just his talk about the history. So the only few information, so I can be sure that ADHD is the correct diagnosis.
Okay, so you want to have further details about his ADHD, making sure that the ADHD would be something that you have an objective assessment about that. Okay. What else? Dr. Muhammad.
About the comorbidities like anxiety and depression.
Okay.
And if that linked with the function at work, function at work with social life at home and with friends.
So the other piece is just asking about how is his function in the work environment, and family history of psychiatry disorder, including ADHD, things like that. What else?
Also about the circumstances that lead him to use amphetamine. Also, why he want to stop with amphetamine, and the symptoms that he feel when he didn't take the dose, withdrawal symptoms.
Okay, good. If he's not taking methamphetamine, what would be the challenges and the withdrawal?
Personality trait before start to take amphetamine.
Okay, that.
Feel with stress, how
What are the triggers for?
coping mechanism.
Okay, what are the reasons for taking meth, and what are the benefits he's making from using meth? Okay, good. So Dr. Muhammad was asking about the comorbidities. Okay, so if you have anhedonia with low mood, if he basically presents that he has some anhedonia without, mood is euthymic, but he is experiencing some anhedonia. How does that change your clinical management? So, okay, so we can, we have a little bit of kind of, at least in my background, there's a little bit of noise, right? So I just want to make sure that we can hear out everybody. So we are thinking how having anhedonia could be something. Or if the person does not have very much of anhedonia, but he has a significant low mood and a passive suicidal ideation as well. How does that change? Dr. Faris.
First, we have to know that temporal relationship between the symptoms and his personal use. So, is that symptoms of withdrawal from methamphetamine, or is that these symptoms related to his use, or it is the history that ongoing started before the misuse? So we can differentiate between these bad symptoms related to addiction or related to psychiatric condition.
Yep. And then let's see if he has also anxiety as well. Dr. Mustafa, right? So he also has anxiety. So, how these psychiatric comorbidities are changing our view about how to manage medications, right? Let's think that he is reporting some impulsive actions and anger outbursts. How does that change your plans for him? If there is an episode of paranoia or reports of paranoia, how does that change the way that you are going to prescribe medications for him? Okay?
All that you're setting here is opening a door for another neurotransmitter. So from that perspective, that would change definitely the type of medication that you have.
Exactly. And yeah. And if we have a significant trauma history, a potentially PTSD in the background, how does that change the way that you practice? If there is an alcohol use disorder on the top of what he's presenting, how all these sort of, and these are the real case scenario. You see these patients all day in your clinical practice. Nobody comes and say, okay, I just have methamphetamine use disorder, please treat methamphetamine use. It's just a combination of all those things together in the real clinical practice that you need to think about and address that. So let me start my talk with one specific study that I really like from a group of people that basically evaluated around 14,000 patients with amphetamine use disorder in Sweden. Okay, who has seen this study before? Anybody who has seen this study before? Okay. So this is a study from Sweden published in almost 2 years ago. 14,000 patients with methamphetamine or amphetamine use disorder, okay? And they followed them to see how many of them would end up to hospital and how many of them would die if you do a sort of a longitudinal follow-up. It's sort of a cohort of 14,000 patients with amphetamine use disorder. This is fantastic, right? So you have access to 14,000 patients who already have amphetamine use disorder, and you are gonna follow them for how long? So they started from July 2006 to December 2018. The median time for follow-up for these patients were around something like 4 years. So they have been following people on average around 4 years, starting from 1 year to up to something like 6 years. But on average, these people have been followed for something like 4 years. And they're some 70% male, and then 34 years old on average. So that's the kind of the population of amphetamine users. At least in my clinical practice, this is the kind of a good representation of what we have in the clinical practice. 30, 40 years old people who are using amphetamines. And they have been following them for 4 years. What is your estimate in terms of how many of these people, almost young, so they're around 34 years old, how many of them would die in that follow-up period? Average 4 years. And how many of them would end up to hospitals? We are talking about Sweden, right? I mean, a system that has the social health system supporting patients. Any estimate in terms of number of people who would die from this 14,000 cases? Any estimate? Dr. Yasemin, what is your number? 10%. So you think 10% of them would die? Okay. Dr. Mustafa, what is your number? Lower than 10%. 10% is very high. Okay. 3 to 5% of the forest. Okay. Dr. Fatima, what was your number? Yep. 1%. Death. Death 1%. 5%, 10%. Okay. So 9.5% death, 82% hospitalization. Is high. Honestly, I was shocked. I was not expecting. I was thinking 3, 4, 5%. Honestly, before reading the entire paper, even 3, 4% is not that kind of low. But 1,321 of these patients died during that 4 years follow-up period. So people actually die, and 82% of them they ended up to hospital. Okay. So the question is, in this sort of clinical population, there are lots of interesting questions that you can ask. One of the questions that we are interested in this specific course is, okay, they have potentially been prescribed medications, right? So if they are being prescribed medication, because they have the registry of whatever medication these people receive, okay? So if I put the medications and then add basically how much that one additional medication saved their life or put them in risk to die, what would be the list of medications that would basically save their lives, and what would be the list of the medication that put them in danger to die? What are the medications that you think about? Can you use the mic? I mean, just making sure we can have that recording as well.
I think medication that reply that make toxicity in lower dose or make مثلا hard toxicity quick prolongation as antipsychotic from antidepressant inhaler vaccine and other
Sounds good.
lithium of because the novel therapeutic techniques also for mood disorder.
Okay. What are the other medications that you think about? Those who have the slides do not go through the slides because I have the answers in the slides, but yeah.
The only factor they are assessing is death with medication, death without medication. Am I right?
Basically, no, this is the outcome here is risk of hospitalization to any cause or death, both of them together. So this is one single outcome measure, the risk of hospitalization and also death. Cedric, do you have any I mean, what would be the medication that would be really bad for these people? That we actually prescribe in psychiatry medication? Benzodiazepine. Ritalin is bad for them. Lithium is bad for them. Okay. So they have a pretty long list of medications. Basically, lisdexamfetamine, which is Vyvanse, lower the risk. ADHD medications lower the risk overall. Substance use disorder medication, I mean different medication that we have for substance use, significantly reduce the risk. We are talking about acamprosate, all those kind of medication that we have for substance use treatment. And then benzodiazepines increase the risk, right? Great job, those who mentioned benzodiazepine as something that increases the risk. But it's not only benzodiazepine, I mean, these are all the medications that we have, right? So the medications could be helpful, could be problematic. And the question is how we know how to do it in the right way. Okay, please. That's another interesting thing, that antidepressants and also antipsychotics increase the risk a little bit. There might be some confounding factors. Those who have been receiving antidepressants and antipsychotics probably were those people who had significant psychiatric comorbidities and also potentially have kind of psychosis, comorbid things like that. But I mean, these are the interesting observations. I mean, this is the data that it speaks. So if you are interested, I would highly recommend you to just go and read the details, how they have been controlling for confounders, how they have been managing those questions. But it's an interesting piece of data to have a sense about, okay, the medication that we are prescribing could save lives or put people in danger, and how to critically think about what would be the right medication and how we can prescribe them. So that is the major issue that we have here. And then the idea of when we have somebody with drug addiction, it's just not drug addiction. It's just all those comorbidities that they come around drug addiction, and we need to consider them in the clinical practice. But the reality is, I mean, you never treat somebody with one single kind of psychotic. It's always a combination of different things, okay? And when you have combination of substance use disorder with other mental health disorders, the question is, what are the pharmacological strategies that you have to address both substance use disorder and other psychotic comorbidities? For Mr. Z, we have been discussing about ADHD, but other psychotic comorbidities as well, how these things are gonna interact with each other. So one strategy is basically, let's treat their substance use disorder first, Because if you treat their substance use disorder, potentially you're going to address their other mental health issues, right? So that is one strategy. The second strategy is to treat their psychotic disorder. And if you address their psychotic disorder, if you address their ADHD, potentially they're not going to use the substances because their substance use was inspired or kind of initiated by their mental health issues. That is the second. The third strategy is finding medications that could address neurobiology basis that would be related to both disorders, addressing both substance use disorder, neurocircuits in the brain, and also that mental health issue, neurocircuit. So one medication for both. Or the combination. Both address substance use disorder, but then you use two medications or two groups of medications or combining different medications. How do you know which one is doing what and how they are working together, okay? And then you also do therapy, right? You want to add therapy on the top of that. And the question is, which type of therapy? How we can go and find the right therapy that is going to work on that part of the brain that we are also addressing with medications, okay?
Maybe the strategies need to be flipped in the context of, yes, it's the combined treatment, but then for this combined treatment, look at the medication that underlies you.
Totally. Yeah.
Now, just saying, in stating the strategies, I would actually choose for 1, 3, 4, and then 3.
Yeah,
okay, we're doing combination treatment, but then we're looking for this combination treatment for the medication that comes from the
I really like your mental process. I love that. Yeah, that is a good, in terms of thinking, okay, this is the clinical practice that we are doing right now mainly, right? So we try to basically combine them together, but how we can find something that would address both of them at the same time. So at the end, we need to have a neuroscience framework that put all those pieces together, giving us an understanding about how these medications are working to be able to combine them. So without that neuroscience understanding, it's just hard to address them together, okay? And if I want to add another level of complexity, if you are also interested to do neuromodulation on the top of that as well, okay? So you are interested to TMS, you are interested to ECT, you are interested to DBS, you are interested to vagal nerve stimulation, you are interested to all those other things we can do, and combining them together, you need to have that understanding. There is a new, I probably have that slide here. No, I don't have a slide that here, but there is a new publication in American Journal of Psychiatry. I have that in my slide. I will show the slide. Just a few days ago, it was a guideline of how to do brain stimulation, especially TMS, for those who have depression or OCD, those applications that we already have the clinical approval for using TMS, while they have substance use disorder. How do you address their alcohol use, their cocaine uses, or those sort of conditions? So, and we didn't like that recommendation guideline. We are right now kind of collecting a new letter to the editor addressing that. Those people who have been discussing, but they didn't have any background about addiction. That is not the reality of addiction. But their recommendation that they provided, and they mentioned that, okay, you need to just ask your patient to stop taking their stimulants before being able to start them with TMS. They need to stop drinking alcohol for a month, and then they can start them with. And that is not the reality of the field. You cannot just tell people, okay, just please stop drinking alcohol for a month. I want to address your depression with TMS to make sure that TMS is going to work, and just ask people, okay, you are going to remain sober. So we need to kind of be realistic about what is happening. So we need to have a mechanistic framework to put these things together. And that is what I really like about applied addiction neuroscience, in terms of giving you a framework that you can understand what is actually happening to be able to put them together. So that is the motivation for addiction neuroscience. We are going to have a break. So I already talked too much. So we are going to have a break, have a lunch. It's going to be prayers break. And then we'll be back at 3 p.m. and we continue the workshop. So we have fantastic group of speakers here. So we are going to discuss, if I have time, I'm going to go to the details about how neuroscience. So I basically showed some like 10 slides. I have some like 200 slides. So we can go through them one by one, different disorders, different case vignettes, and discuss how neuroscience could inform our clinical practice in psychiatry. Thank you very much.